I'd like to acknowledge the traditional custodians of the land that we're meeting on today, the Gadigal people of the Eora Nation, and pay my respects to elders past, present and emerging, and welcome any Aboriginal people who are here today. I'd like to also acknowledge the individual and collective contributions of those with lived experience of mental health issues and suicide, as well as family, carers and kin who are here today. Your insights, contributions and advocacy to influence positive change is vital for the human rights of us all. Nothing about us without us. And now I'll move on to today's event. We have, as you see, a panel to start with. Some very esteemed panelists who are each going to talk for 5 to 10 minutes each, hopefully around 5-ish. Then we're going to have a little discussion just to dig into some of those points that were raised. And then I'm going to step down and there will be a spare seat at the front, which anybody from the audience is welcome to come and sit in and continue the conversation. And anyone at the front can go and join you in the audience at any point. Anyone from the audience can come and sit in any spare seat that's available at any point. The reason we do this kind of setup is to break down that idea of the people at the front of the experts. We feel at Being that everyone is an expert in their own lived experience, so everyone has something to contribute. So please come and be an expert, a so-called expert at any point. There is a spare chair. You can always also, if there's a few people waiting, you can wait at the side if you like to. We're pretty chill here, so just do what you need to do. So I'm going to stop talking now. Sorry, I forgot to mention one thing. Everyone, you can only talk for 3 minutes at a time. So you can stay seated here, but we're asking for you not to take up too much of the space because we do only have an hour and a half today. So there will be an alarm, which Julian will be monitoring to make sure that, thank you for testing that. And yeah, please be mindful of that, please. I'm going to introduce the speakers just in order of how you're seated today. So I'll introduce you before you speak. So the first person is Andrew Shim. Andrew is a suicide prevention peer worker and has a particular interest in the specific nuance and needs of suicide prevention for both the neurodivergent and COLD communities. Andrew, you're welcome to stay seated or stand at the podium. It's up to you.
Hello? It's working now? Yep. Hi, hello. My name is Andrew Shim. Thank you so much once again to Being for organising and facilitating this event today. What I'm hoping to bring to today's discussion is not only my experience as a person with lived experience of suicide and taking care of someone who has gone through a suicidal ideation, but also I'm hoping to add my experience as a policy analyst. So I've been working in this particular area of mental health reform for, I think over 7 years now, despite the fact that I look quite young. My perspective on this discussion is that suicide is often treated specifically as a health-only problem, when we know from all the research that there are social determinants to suicidality. I am very much cognizant of the fact and commending the fact that there are some really encouraging reforms. For example, with the Suicide Prevention Act that I'm sure that Julie would happily canvass and discuss, but also I think the parliamentary inquiry into the impact, prevalence and causes of loneliness and social isolation. What I hope that we can help disinter and illuminate today, however, is ensuring that we don't apply a monolithic approach to some of those discussions around social determinants. I come here as a proudly autistic LGBTQIA plus first-generation immigrant, and a lot of the times people will look at someone like me and say, you have to pick one of those buckets. You're either a person with disability, or you are a queer person, or you are a immigrant. You you can either be multicultural or queer. You can't be both. And I think that homogenous, conflating approach to not only suicide policy reform, but also, I would say, mental health reform at large, leads to, I think, an approach that perhaps is not the most congruent with human rights-based approaches. And I'm hoping that discussions like these can continue fostering the encouraging progress we're doing towards an intersectional society. So that's my little two-piece. If I guess Julie's the next person sitting to me. So.
Fantastic. Thanks, Andrew. So I'll introduce Julie. This is Julie Dixon, who is the Director of Priority Projects at the Mental Health Branch at New South Wales Health. Julie is responsible for overseeing and evaluating the delivery of suicide prevention initiatives across the New South Wales health system and primary health networks, including towards zero suicide. Thanks, Julie.
Thank you very much, and thank you to Andrew for raising that important area around social determinants of suicidality. I was just going to speak briefly about, as Andrew mentioned, that this government has made an election commitment to develop a Suicide Prevention Act. And to inform what that act might look like, the team and myself and others have looked across jurisdictions, and importantly to South Australia, which we know, I think many of us are aware, have a Suicide Prevention Act. And the reason for doing this is because we really do need to instigate a cultural shift in government, as Andrew well put. It's not just a health issue, it's very much a much broader social issue as well. And so really this act is about the idea of collective responsibility across all levels of government and establishing mechanisms for clear accountability as well. And why is this the case? As Andrew said, there are many different factors that contribute to suicidality, personal, societal, and as well as structural factors. And we know that mental ill health is one factor, but it's far the only one. We know that around half the people that die by suicide have not accessed health services in the last 12 months. And many people who lose their life to suicide do not have a mental health condition. And because there are many risk factors and social drivers of distress, and many people in the community do have regular contact with government agencies, Service New South Wales, Legal Aid, etc., a whole of government approach is required to address those social determinants of suicide and, importantly, look at more collaboration across those governments and better coordination so no one loses out in receiving the care and support that they need. We also know that through surveys with people who have survived a suicide attempt, that many had not been contemplating suicide for that long. In particular, there's a study that showed around nearly half of the people who attempted suicide indicated that it was within hours or minutes. These findings really do demonstrate the importance of addressing the drivers upstream so that we can provide early and ongoing support to people who might be experiencing distress. So this act has been the idea of an act at the moment is we've been consulting with government agencies and importantly with people with lived and living experience of suicide by engaging Suicide Prevention Australia and First Nations Co. At the moment, we've been considering 6 potential inclusions, very much modelled on the South Australia Act. But importantly, we're also been really keen to hear about what hasn't government considered or isn't in the various reports that we've been reading through Suicide Prevention Australia as an example, or Roses in the Ocean. So we've actually spent the last 4 months consulting with other government agencies, but as I said, through these 2 peak organisations, we're really extremely keen to hear about what the community is telling us, because we absolutely need to have a responsive act that provides more of an effective system. So I'll just quickly touch, Julian, if I got a minute to go. Okay, I'll just quickly touch on the fact that at the moment, the 6 potential inclusions include a state-based plan that would have specific actions and, importantly, have a focus on those particular groups disproportionately impacted by suicide. Andrew's made such an important point that that intersectionality across the different groups is so important. Transitional points are often where people fall through the gaps. So your point is a really important one for this Act. We're also looking at agency-based plans as well, again with specific accountability mechanisms as well. We're looking at a suicide prevention council, and I think Ellie might touch on that in her speech, so I won't talk too much about that. And importantly, we want to make sure that people with lived and living experience are at the heart of everything that we do across the government. I'm very much aware, and as Fee's in the audience here, that the Mental Health Commission has come up with a fantastic tool which can look at which government agencies can use to assess how well they are embedding and amplifying the voice of people with lived experience. The other area is around building the capacity of the workforce itself. We have a workforce not only looking at the workforce that supports people in the community, but about the workforce themselves. That's equally important as well. And really looking at providing compassionate, inclusive, culturally safe care and support, and no one is left behind as well. And then finally, I think I just wanted to mention about data collection and sharing. That's equally important. We have a suicide monitoring system, so the potential to enshrine that in legislation. And finally, the last one, which has had a lot of deliberation with many communities and government, is around the impact on policy decisions. You know, that impact on those significant policies and looking at what that threshold might be, because at the end of the day, we don't want policies to cause more harm, but we know they can do. So thank you. Yeah.
Thanks, Julie, for that overview. We are now going to go to Ellie Hodges, who is the CEO and founder of LELAN, which is South Australia's peak lived experience consumer organisation. So basically but in South Australia. Ellie is an experienced counsellor and therapist and is also an individually appointed member of the legislated South Australian Suicide Prevention Council and led advocacy work to embed the alternatives to suicide approach across South Australia. Thank you.
Thank you. The work to bring alternatives to suicide systematically to South Australia was a long journey that we've been on now for 4 years. In 2020, we received a small grant we said we would interview people on film about their experiences of accessing support for suicide distress or crisis. We really wanted to know what helped, what harmed, and what could be done better, based on the premise that advocacy that just highlights problems without solutions and your hand to be part of enacting them is shit advocacy. So that's why we asked those things. We did put out a 38-minute documentary that's on our website, still extremely relevant. But through that process, there was a thing called COVID that delayed production multiple times, even though we're in SA and much less impacted than other places in Australia. But through that, we did a survey because we thought, well, we're not doing much, so we'll do this. And we heard some alarming stats from community and just over 100 people that replied. 76% said that they strongly disagreed that services and supports adequately met their needs. 63% felt that care and support that first time they reached out was much worse than they expected. 79% strongly disagreed that they felt able to be honest with others about their thoughts and feelings about suicide. 92% strongly agreed that they felt alone and like they had to work it out for themselves. And 78% strongly disagreed that they felt services wouldn't hurt or harm someone in any way tomorrow. Throughout this, we also heard through the survey and the people we interviewed deeply for the video is that peer-led, community-based options is what people want and need. And since that time, all of the relevant documents at jurisdictional and federal level, the policies, the reports, all the talk is lived experience. But we don't see that structurally embedded or programs actually fully aligned with that. That led us to, I put out through our networks, is there something that already exists found out about Alter Sue and that it had been going for a couple of years in WA with trans folk and another group as well. We connected with them after some very hard advocacy, 18 months from when we felt that, so we ended up getting funding from, in South Australia, we have 2 PHMs and a government department added funding, and we invested ourselves and paid for ethics approval so that we held data, and there's power in that for lived experience to have that sovereignty there. And so it was 18 months from when we thought we would get funding to when we signed contract. Because what we also held really strongly on is that, and I still hold this belief in Australia at the moment with the systems that we have, is that peer-led initiatives cannot be governed by clinical governance frameworks. And if we were going to fully test and pilot a peer-led community-based option around suicide, particularly where there's rights breaches much more enhanced than in other areas, that we would have to hold that. So we got Alter Sue and it's been going well. Since 2022, when the first group started, we've had 547 people attend. There's been 10 different types of groups, LGBTQI focused ones, online ones, in person. There's some adaptations. There's one where they play tabletop games after an Alter Sue group. So it can be done. It takes a lot. We have had someone who did take their life connected to Alter Sue, and our response was very different to what you normally do. We connected with our community, our facilitators, and held an honouring and witnessing before we even notified funders, when normally that's the first thing you're meant to do. Because if we were upholding Alter Sue values of community, connection, validation, social justice issue, we had to lead with that in every aspect. So that's Alter Sue. There's more info that I know has been shared and can talk more about. As Julie said, and Priscilla, I am, and so this bit I'm speaking as Ellie the human, Ellie, like all of me, not in the role and not on behalf of the Suicide Prevention Council, just to do that declaration. I am an individually appointed lived experience person. I clearly take all of my work in my life because I can't not breathe it. And I've been on the council for 2 years now, and in thinking about the council and how to set it up effectively is to think about how any committee that meets infrequently can have impact. And if you are really clear about the scope and scale and the vision, to write that into the legislation clearly, otherwise you will limit it, because when we are stuck, we go back to legislation to define our role. And so that can stop us in our thinking and the possibilities around it. So that's really important. What will the focus? Who will be represented? We have individuals who represent different types of communities. We also have ex officio people. So these are commissioners, chief psychiatrists and others who come because of their roles and give different knowledge. We do regional outposts. So a couple of weeks ago, we were in regional South Australia. We go once a year just to hear from community and be grounded and connected to them and give them an opportunity. And which parts of the system will we influence? So we have the council, and we are only responsible for overseeing the suicide prevention plan in South Australia. So that limits our scope. It's taken 2 years. It's a slow process. It's taken 2 years just to sign off on what our measures will be, our lead and lag ones. So it's also being realistic and setting expectation for people as well. Or maybe there's different structures that speed things up as well. So that is some initial thoughts and my contribution. Thank you.
Fantastic. Thanks, Ellie. So finally, we have Stephen Smith, who is a suicide prevention peer worker. Stephen has his own lived and living experience of suicidality. He has listened to and reflected on dozens of people's stories and will share his personal thoughts on what support people living through suicidality want. Thanks, Stephen.
Thank you. I want to thank Being for this opportunity. And as I begin my talk, I know my comments are my personal observations. They do not represent the opinions of any organisation I may be employed by or associated with. Across my life, I've had the experience of being a carer for, bereaved by, or providing services to suicidal people. Today, however, I will be focusing on lived and living experience of suicide. I define this as having thoughts, plans or actions related to wanting to kill myself. I've had these experiences since 1980, but due to the stigma and discrimination around wanting to kill myself, which can be described as suicidism, I first reached out for assistance in 2018, some 38 years later. I was on my way to putting my thoughts into action, but that day I did something different. I stopped and phoned a friend. The call didn't go as well as I'd hoped. My thoughts and experiences were framed as emotional blackmail. You may be able to imagine my distress and aloneness at that time. In that moment, my lifelong intuition about how unsafe it was to speak about the thoughts of killing myself were confirmed. 3 years later, I became a suicide prevention peer worker, and my journey with suicide was outed to my friends. I discovered I wasn't the only one experiencing these things. I've talked with friends, associates and clients about their experiences of wanting to kill themselves. And a key message that has been burned into my brain from these talks is safety is critical. We need places that we define as safe in which to discuss wanting to kill ourselves. A story I often hear is that people who come to services for help, if they feel unsafe and at risk, they keep themselves safe by telling a very heavily edited version of their story. People tell enough to get a little bit of help, but only enough, because they want to avoid an involuntary rescue, or they simply avoid altogether engaging with services or people who may call 000. I believe the suicide prevention sector is yet to adequately listen to our concerns. Let me illustrate this by my mate Bill's story. He doesn't want an involuntary rescue. He chooses to say no to police, ambulance, locked wards or medication. He would rather choose death than not have power, control or choice. He would like to reach out to a hotline where he's not at risk of an involuntary rescue. There are none. If he was in the US, he would have options of reaching out maybe to something like Trans Lifeline or other services if he belonged to a minority group. Given he has no supports, the journey to killing himself is a certainty. This now means several things for Bill. He'd love to have people along on the journey with him. He'd like to be able to say appropriate goodbyes and have a safe end-of-life medical procedure. This medically aided dying process is available to some people in Australia, but not to those of us with suicide or mental health issues. He'd also now need to know, well, what's the most effective, painless, less traumatic way to die? He notes that the suicide prevention sector is making it harder for him to access this information. This is likely to mean less effective or more violent means. If he's unsuccessful, he risks an ongoing life of disability. He would like to be associated or accompanied, by his close friends. Suicide legislation places them at risk of prosecution if they're involved. As a good friend, he would decide to die alone by uncertain means and probably violent ones, and he worries about the impact that his death may have on the public. If he dies, aspects of his story will not be reported. Means are not reported by the media. He actually wonders, how will the public become aware that the suicide prevention sector is actually covering up the horrendous pathway that has been left to him. Bill is distressed not so much by the thoughts of killing himself as by the pathway left open to him by the sector. This is why he has been happy to actually have himself identified by his real name today. So what do people who are having thoughts, plans or actions related to wanting to kill themselves want? A number of key things. But I'm out of time. Thank you for listening.
That was a great way to end. Thanks, Stephen. I'm really surprised that one thing hasn't come up. I feel like it's kind of an elephant in the room, and that's police. My favourite topic right now. Being ran a survey, I'm going to say about 6 months ago, asking people, who do you want near you or with you when you're experiencing suicidality? Now, if memory serves me well, it was friends. No, a friend's first, a friend, or and then peer worker, I think, or maybe it was the other way round. So peer worker first, then a friend or family member. It was a long list of about 10 or 15 possibilities you could choose from, and at the end, last was police. So potentially, although it could be all ages. I'm 50 and I don't want police near me when I'm experiencing suicidality. So I love your point, Stephen, about silencing, because I think that having police potentially involved has that silencing effect. Whenever I've experienced suicidality, I have never wanted to tell anyone at the time. I just keep it to myself. And that's not a nice way to be when you are in distress and you feel like you can't talk to anybody. So what I'd like to discuss, if we can, I have hope now that Julian's working on a new legislation that potentially we can just rule police out of this whole thing. Is that how things have worked, Ellie? And Julie, what would it take, or do you think that's possible in New South Wales? And Stephen and Andrew too, of course, say what you will.
Mind if I jump in first?
Can I just jump to Ellie first? Because I'd really love to hear from South Australia how it works.
So within Altasoo, there's a charter that we abide by. One of them is responsibility to, not for or over, and it's the most fundamental thing, and crosses over this and changed my advocacy for everything and gave language to it. So very simplistically, current approaches to if someone says living is hard, I don't want to die, is a risk assessment starts immediately with or without them having knowledge of that. They will be directed to ED or GP, and police and or ambulance may be called without their consent as well. So the system takes a responsibility over believing we don't have control or choice to make for ourselves, and we need them to do it and we're absolved. Altasoo, the responsibility to, not for or over, says that if someone says living is hard, I want to die, they come to our groups 90 minutes, weekly, fortnightly or monthly. You can mix it up a bit. Someone says those things, they are sat with. There's no risk assessment at all. If they say their name is Fred and they leave, there is no welfare check. There is no police, there is no ambulance or anything like that, unless they choose that. It's their choice fully. This has been operating now for 2 years. We've had groups going and we've abided by that. The only time police would be called is if there is violence in that moment and people are unsafe, but not because of suicidality or anything like that. Allows us to do that. I think I forgot to say this when I talked before, when I said peer-led can't operate under clinical governance frameworks. We argued, and why it took so long, we got an exemption from our funders that was the first in South Australia and maybe the first in Australia to be able to do this. So it takes that as well.
Hi. So I had the immense privilege of being appointed as an autistic member of the National Autism Strategy Oversight Council, overseen by Minister Rushworth, to help oversee Australia's first national autism strategy. And police was a large factor in, I think, in discussing not only autistic people, but I would say people with disability at large, and that includes people with psychosocial disability. What we found in all of our research and consultations is that police were often cited as an escalating factor, I think, for not only, I think, mental health crises, but I think especially for anyone who is going through suicidal ideation. From my understanding, thankfully, I think in the last, 2 months or so, New South Wales Police has at least acknowledged that they are often an escalating factor to, I think, mental health crises in general. I think, unfortunately, there is still more that we can do to ensure that first responders, especially police, are not only trauma-informed, but neuroaffirmative and are actually cognizant of what lived experience is. The number one, I think, recommendation that I would have is ensuring that police officers actually are mandated to undergo comprehensive and intersectional training that around not only mental health but also neurodiversity. We know that autistic people, for example, and neurodivergent people are 5 times more likely to be victims of crime than they are to be perpetrators of crime. And yet when police are often called to someone who is, say, experiencing suicidal ideation, they're often treated like they are the criminal, when in reality they are often someone who's incredibly vulnerable, might have been a victim survivor of domestic violence, or has lived experience with a number of adverse childhood events. And we want to de-escalate the temperature, not escalate it. I am encouraged by the fact that the New South Wales government response at least acknowledges that New South Wales Police have acknowledged that they are an escalating factor, and I hope that this can be the start of, I think, as Ellie has mentioned, bringing the control and the autonomy back to the people who are the most impacted. There's a saying that I often like to bring up in these discussions, is that when it comes to policy making, power has to be brought to the people who are closest to the pain. And what that means is that the people who have the most pain associated with that policy should be therefore located the closest to the policy-making process. And in this case, I think, for example, people with lived experience of suicide, but also people who have that lived experience with interacting with police should be, I think, centered in some of these policy reforms regarding police. So.
And I would extend that one step further. There is no place, I think, and there may be some like LELAN, where suicidal people actually have control of the full conversation. Most organisations that speak on our behalf are actually controlled by people who are either carers or service providers. We do not have a space where we can sit down together and work out the best solutions. We need to change that, because we're the people with the pain, but we haven't been given power and control in our own organisation to make decisions about ourselves.
Wow.
Sorry to put you on the spot.
No, this is why I was actually very keen to come today, because it is about having the conversations and hearing what's needed from community, especially people with lived and living experience. And I guess that's why we have made sure, and I will say this minister has been incredibly committed to being inclusive and undertaken a fairly lengthy consultation as much as possible, and very much listening to what those needs are. And that's why these reports are going to be really important about that feedback, including here today. I can totally understand exactly what everybody has said. And in fact, I spoke to Lifeline the other day just to talk about their decision supports around when somebody does call their line. And it is very much at the bottom of when police are called. But I totally get the understanding that a peer worker why people have said a peer worker would be really good. And I guess would like to say that that's the case in EDs, emergency departments as well. And I know some of the local health districts are looking at employing peer workers. In order to do that, we need to grow the workforce. But to grow the workforce, we need to make sure people have the opportunities for things like the mental health certificate if they want to do that. So we're looking at scholarships there as well, and diversifying the workforce as well, whether it's peer navigators, suicide prevention, peer workers, mental health peer workers, et cetera, et cetera. And I am really, to be honest, I've been in the public system for 40 years. I opened up some of the first needle and syringe programs in New South Wales in the mid-80s, and I had peer workers. People needed to have even a current living experience or a lived experience to work. And I could see the effectiveness of those programs absolutely contributed to reducing, HIV across Australia. So I'm very much, my background is nursing, but I went into this field and realised I wasn't an expert at all. It was the people who lived in living experience that were the experts. So I come from that lens, and I understand what you're saying around the clinical frameworks as well. So I get that. It's about that balance as well. And of course, I have people above me, but I'm hearing what you're saying. I'm hearing that feedback, and it will be contributing with all those reports together for government consideration. But yeah, so thank you. Appreciate it.
Thanks, Julie, and thanks for being brave enough to come and answer our questions as well. Because yes, I was going to ask, do any of you have a question for each other? But Ellie, please.
I just wanted to say one thing to, I guess, everyone is there's a different framing. We're talking about suicide prevention. Alternatives to suicide isn't about preventing suicide. It's harm reduction. And you just mentioned in the early 80s and around HIV, like the peak body, our history is in the HIV men's gay movement. And so when we look at their practices and approaches as an advocacy, harm reduction is more aligned.
That's a great point. Thank you.
And I will add, there is a very important work called Undoing Suicidism written by Alexandra Burrill. He's one of my heroes at the moment. He has a, what do we call the model of care rather than prevention? He has a travelling along with model, and that model needs to be considered. It's a long book, but he's got a wonderful YouTube clip, and I will have business cards with me that will give you links to that particular YouTube clip that I can give out today.
I'll second that. I think that his work is fantastic. It is definitely worth looking to Canada because I feel like they're so far ahead of Australia in this space.
That's something as a society we need to reckon with. The system, and when you take suicide prevention, it keeps it as a wrong, but for many people to continue to live is knowing that is an option. There's actually a safety for some people to know they have it, and we don't want people to take their life, but I also don't assume to believe I have the control of another person to stop them as well.
Do any of you want to ask someone else a question on the panel?
I have one for Ellie, actually. I actually flew back from South Korea last Thursday, hence why I think I have a little bit of a flu symptom. It's not COVID, everyone, I promise. There was a sick child on the plane. In South Korea, as some people here might know, is I think the OECD country with the highest suicide rate. I think it's the fourth highest suicide rate in the world. It is one of the few countries with suicide prevention legislation that, as was mentioned in the New South Wales discussion paper on suicide prevention. When I was in Seoul recently, speaking and meeting with not only autistic advocates, but people with lived experience, what really struck me was, I think, how South Korea would take a different approach based on each demographic. For example, they recognize that young people in South Korea who have lived experience of suicide, that the way that they approach that demographic is fundamentally different from the way they were treating suicidality in aging Koreans because they noticed that it was almost like a U shape where there were two spikes on the different ends of the age spectrum. I know that this is a very long preamble. My question for you is regarding South Australia's initiatives. One, do you think South Australia and government initiatives at large do take that, I guess, bespoke approach to different demographics? And if not, how do you think we can particularize the way that we're approaching suicide to ensure that we're actually meeting priority population cohorts?
That's a big question. So just some brief thoughts is through AltaSu, because people put their hand up to facilitate groups and then they have a 3-day training that they go through, and it's generally because of their interest or identity and intersections that groups are formed. So that's how we have the LGBTQI. We've had rural as well, but we had to adapt to that because people going to groups in rural areas and confidentiality was a challenge and things like that. So that's how ours have emerged. And we do really well with the queer community, I guess, to represent. I know that in WA years ago they did talk with First Nations elders about whether AltSu was appropriate and relevant for them, but I don't know that, there hasn't, actually there's Blackfella, which is Queensland or Northern New South Wales, there's a group online for AltSu as well. Holistically, I'll just speak for SA, and it's just an opinion. I think we do intersections and priority groups really shit. We haven't cracked any way that we don't give space for it, particularly in policy. And quite frankly, I grew up in regional New South Wales and I now live country SA, and it's a major divide. And part of it is population, to have initiatives and activities like that. And I'm still gobsmacked after 18 years living over there, how metrocentric South Australia is and how white it is as well around that. So I think there's, other work LELAN has done around lived experience leadership, we intentionally built in intersectionality into our research because it was a gap that we wanted to put on the agenda. And I think people are starting to talk about it and use that word now, but to actually translate that into practice on the ground, there's some hard work that needs to be done.
I need to get your business card after this. There's like so much more that we can talk about South Australia. Sorry, Julie?
No, not at all. I was going to ask Stephen, actually, because Stephen works in a safe haven, don't you? And works closely with the suicide prevention outreach teams. And I was going to ask you about how well you think, how well they fit into the system overall.
I think for people thinking about wanting to kill themselves, safe haven is the safest place in what's currently available to us within the public health system. People who come along love it. They love not having to go to ED. Who wants to go to ED? I don't. I went there recently when I was up in Townsville, spent 8 hours. That was for a physical health thing. It's terrible. So this particular initiative is quite amazing and it's groundbreaking for health. And if you want to know what do people who are thinking of killing themselves want, they want more safe havens. They want it to be 24 hours. They want it to be available in more and more places. That's part of what we want.
I couldn't quite hear what you were saying, but I jumped up here. One of the reasons I joined being as a member was when I was working at a safe haven, and my experience with the police for my client was atrocious. It was shocking. It really affected me as well, which is one of the reasons I joined being in the first place. So when we started with police, I got very excited. I'm ADHD as well, so I'm very jittery, so I'll try and talk slow. But police response to mental health as a first responder is terrible, to put it lightly. With the report that just came out, as Andrew was sort of saying before, it was recognised that police are essentially always an escalating factor for mental health calls, and that there was a large number of people who were dying at the hands of the police after a mental health call, which is totally unnecessary if you're calling for mental health support. And I'm now working with The Way Back, which is an incredible program for the Nepean area. And part of that was spending a lot of time talking with the police, because we will have to work with the police a lot. And they do mental health training. The problem is that if you go into work as a police officer, you're not going in to care for mental health. You're going in to look for the bad. So when they're coming into situations, they're just looking for the bad and the scary, and they're not looking to be empathetic or sympathetic. They don't understand trauma-informed care. They don't understand, when we're working as peer workers, we have to explain so much to them. And when we say someone may have used some sort of medication, they take it as a drug issue, and then 10 police officers come in for one small woman who just needs some help, which is not okay. We do need peer workers to be coming out first, and it sort of bases off the UK model, which is where we got our safe havens from, which we're slowly starting to do with the PACER model, but still with the PACER model, you have to have the police come out first, and then they call PACER, which is not, it's still escalating, it's still not appropriate. And then the only option that they have if somebody needs support is to go to EDs, which is another issue that in and of itself is traumatic and harmful at the moment in the way it's set up. So I think we really need to, really relook at this and how we're sort of doing this, and actually putting the person first, and having a person-first approach, not, the police shouldn't be involved. They don't need to be there unless there is violence. This is a mental health issue. It's a health issue first and foremost. So mental health is health. So if anything, it should be paramedics, but they can't even come onto the scene until a police officer's there. If we, as a safe haven, call the paramedics, they say we have to wait until a police officer's there. And even if they do come, they don't prioritise it. Police or ambulance don't prioritise mental health because no one's bleeding out and dying. But, if we're sitting here making people wait 2, 3, 4 hours for support is not okay. It is not safe. And I can't think of anything else. But, yeah, so I think it's a really important topic, and I'm so glad for the report that just came out about the police. And I really do believe that they need to be taken out of that situation. They just don't understand it, and that's not what they're employed for. So, yeah.
And I will make my last comment and then I'll sit down from the stage. It's unfair of us to place this burden on the police. In a former life, I've worked in the justice system as a probation and parole officer. I've spent a lot of time with police in rural, remote areas. There are wonderful people doing wonderful job, a very, very, very exceptionally difficult job. It's unfair that we have placed this burden on them, and we need to take this burden off them. Thank you.
Well, as a fellow ADHDer, I just firstly wanted to thank you for sharing, I think, that particular insight, which I think I'm glad that people here could hear. My particular perspective on, I guess, suicidality and everything that was raised in that discussion is that it kind of reinforces for me why many people in the disability community are so passionate about a human rights-based approach. Because I think if fundamentally speaking, if we accept and acknowledge that there are certain inalienable rights, and there's certain rights, for example, a right to safety, a right to privacy, etc., then therefore any actions that are taken, even if it's under the auspices or aegis of supposed health intervention, it would infringe or abrogate a certain right that's inalienable and therefore be considered a human rights infringement. What I'd be really curious to hear about from everyone here is how do you think we can, I guess, safeguard the human rights of people who are have lived experience? Because the viewpoint of the Australian Autism Alliance, for example, and autistic and neurodivergent stakeholders has consistently been a Human Rights Act or actually legislating human rights in general. But I'm keen to get people's perspective on how to actually safeguard those rights and what sort of mechanisms we can implement to ensure that we're protecting, say, human rights, essentially.
Well, I think taking that human-based rights approach is really critically important, and the draft National Suicide Prevention Strategy indicates, recommends taking that human-based rights approach, and through, if the legislation includes a state-based plan, then that would be one of the key principles, such as in the national strategy as well. So I think, but it's about how you translate that at a practical level, isn't it? And it's always in that, it's not about the plan, it's about how you implement it. And yeah, so I'll be keen to hear how that's going, because you've got a state-based plan. And the council are responsible for monitoring that implementation, Ellie? Is that right?
We do, yes. Yeah. I would say I probably wouldn't reduce it to the council and the plan around rights. In South Australia, we have had a select committee inquiry at the start of the year around whether we should have it's called the potential of a Human Rights Act. So there's action happening around that in SA. I don't know where it's gone. We also have a Mental Health Act review being drafted to bill at the moment. It's taken 2 years for this review, and our reviews happen every 5 years. So I think when we look at human rights and how we support that in ways there's the policy and translation, it's looking at where we actually contradict ourselves. We have mental health acts that talk about elevating human rights, whilst it also legislates and gives permission to have our rights breached in really clear and obvious ways. I don't think there's a really easy answer at the moment, and that's some of the grappling that needs to happen. But if there are rights about our autonomy and choices we make, then that would include to live, and it would include to die as well.
I really believe that the answer to a human rights approach is the safe havens. They're incredibly underfunded, and, they're, 3 people with peer lived experience who are there every day, no matter what's going on in their own lives, because they literally don't have anyone to cover for them. But safe havens are one of the most ethical human rights sort of based approach. It's the one in Penrith is completely anonymous. When I first went in, they literally said, you can say your name is Santa Claus and tell us whatever you want, and we won't follow up, we won't talk to you again. And it gives you that place to really be safe. And they also have their own lived experience because they're peer workers as well. The problem is they close at 9 p.m, or they close on the weekends, or they're not open all the time. I know our local one is from 2 p.m. till 10 p.m, which is fantastic. It's a fantastic start. But that really, in an ideal world, would be running 24/7 and would be continuing to run. Another problem with those safe havens is usually they're run in connection with something else like a head to health or whatever it's called now. And the clinical workers there don't appreciate the value of peer workers. So the peer worker turnover ends up being huge because the clinical people who are also meant to be there supporting these people don't understand peer work and just think you're just someone, who's just having a lardy day, but you don't actually value the lived experience of that. But I'd say safe havens really need to be pushed. There needs to be more. They need to be run longer. We need so much more funding into them because they have provided so much more benefit and kept people out of hospital. And I know people that I've worked with and my friends and peers are way more likely to go to a safe haven. They feel safer. They feel more respected. They feel that they can speak about things. But yeah.
We need those spaces, thank you. And I'm going to say one thing and then pass to Human Inside at the end, which I love that. If we're taking a fully human rights approach around this as well, then it's about housing, it's about universal basic income, it's about addressing all of the social issues which actually get people to that point. That's a human rights approach to suicidality.
Yeah. Oh. Come on.
microphone here.
Hello. How do you do it? Come on. Oh yeah. Hello. Okay. I just have a question. Really, I don't want to ramble. I just want to ask a question. But it's hard because sometimes I ramble. The question that I have may come across as antagonistic, and I don't want to sound against something, but I've spent most of my time this year feeling really passionate about an alternative to mental health first aid. And I find myself extremely, I guess, upset because I constantly see mental health first aid being rolled out. And yet, and I understand, like, what we're recognizing here is that we keep saying it's like an issue that everyone's responsible for, really. And we're training out, we're basically, it's irreversible. We're literally we're turning it's almost like we're turning our entire public into like exactly what I feel we don't want, like from a lived experience perspective. And there are alternatives, and yet they're just like, I feel like it's just invisible. It feels invisible. Yeah, so I'm just wondering what's happening with that. I don't know what's happening with that, and what I'd love to hear about any of the work that people are doing or know about that's addressing this, because it's just always in this like benevolent. I think I'm really frustrated with this kind of benevolent thing of like, yay! We got our mental health first aid training done at our organisation or our school. Yay! Oh my God.
I've actually done the mental health first aid as a... Oh my God.
Thank you. I've done the mental health first aid and it's about to expire. I'm not going to do it again. I thought it was a bit of a puppet show. Yeah. So, yeah, I don't think it's very effective.
Like I'll just drop. I've been doing emotional CPR. Hats off, and hats off to Matt Ball in Adelaide as well. Just listening, hats off to him.
So you just mentioned eCPR, which is what I was going to say. That's what we need to be spreading. It's a 2-day training that supports people to sit with others in connection and just to listen and validate and resonate with them. That's what we need. We don't need mental health first aid, which just teaches diagnosing of more people and pathologising us.
It's also like, it's stop the expert thing. We all have the capacity. We at times, yeah.
I was just going to add to that by talking a bit more about how we don't even need to necessarily reinvent the wheel. There are so many wonderful solutions out there that we could be pursuing as alternatives, but what we need to do is build more, I think, not only goodwill, but also just a straight up awareness and knowledge and acceptance of them. One of the things that, for example, in the autistic community that we've talked about quite often is that we know that the suicide rate for autistic people is 7 to 8 times higher than that of the general population, and that the suicide rate for autistic and neurodivergent people is the highest amongst compared to any other disability cohort, whereby the suicide rate for the generalized disability cohort is 4 to 5 times higher. What myself and other autistic advocates have been pushing for is ensuring that autistic people and neurodivergent people are not forgotten about in the development of not only mental health first aid programs, but also suicide prevention policies and programs at large. We know from the research as well as from the lived experience that a homogenous rather than a heterogeneous approach to mental health policy underserves key demographics such as autistic people, as well as how a homogenous approach to, say, LGBTQI plus people may underserve, for example, trans and non-binary people. What we're really trying to do, I think, and what we're touching upon in this discussion is that there are so many wonderful programs and initiatives, but right now they are often catering towards a specific type of person that is almost assumed to be the standard Australian, whatever that standard means, when in reality, we are more than just the individual parts of our identity. A lot of us intersect multiple communities. A lot of us are like Russian nesting dolls, or whereby we are a subset within a subset of a minority, and that therefore what many disability advocates are hoping that we can at least acknowledge as part of this discussion is that when we are developing programs and training such as mental health first aid or suicide prevention policies at large, that we don't inadvertently or not do a conflationary approach that tries to lump everyone into the same bucket and thereby inadvertently or not de-individuate some of those really personal lived experiences. Because I think ultimately the people who will be the most adversely impacted by that homogenous approach and that homogeneity are the most vulnerable people and the most impacted people.
Just to really quickly, an alternative for the mental health first aid, Living Works Assist program, I found is a really good choice, or the Living Works Safe Talk.
Thank you.
Hi, everyone. Unaccustomed as I am to public speaking, I've been getting a lot of practice. I'm here because last year on the 20th of July, my son was self-harming and the neighbour called the police and the police came before the ambulance and they shot him dead. And so I saw a problem and I decided it's all very well everyone having a problem, but nobody has a solution. So when you've got a problem, you need to say, and this is how you fix it. So I've been advocating with very good support from several ministers of several different parties. I've been in touch and had meetings with the police union chief, and there is no doubt that, and I feel quite a contributor to this, that the police do not want to be the first responders, that they will not be the first responders. But in order for them to get out of first response, there needs to be an alternative. And I've been pushing very hard for adding mental health to 000. Recently, there was a Channel 10 item after the police report came out, which seemed to go towards my view. The Premier had one sentence in this program, news item, which was, "We can't get the workers. Get another job, Premier." And then the Minister for Police, Yasmin Catley, said it was a practical idea and solution. Now, when you've got a problem and a solution and you're in the position that you can do something, what I think is needed is a list of lived experience people, because we all talk about let's get them in, but nobody fucking does. I've sent the head of the union and the ministers something I was sent from Montreal about how to solve this problem. Adelaide is right up there with that, and New South Wales is spending billions on buildings, airports, getting people out of Sydney out, and no money on mental health at all, which is why I went national, because it's up to the government in my view. And everyone here needs to say, okay, we've got the problem. This is the solution and we want you to take it, because it's such a huge problem. And that's why I've been fortunate in some respects to get the support of ministers. Unfortunately, although Yasmin Catley knows about me and would like to meet me, she can't meet me, because when you're deceased by the police, it's your fault. And there's a 3-year coronial inquiry wait, so they're worried about their conflicts of interest and so on. But I'm about to hit the wall soon. I've got to stave that off. But the people here, I've been fortunate enough to be given the opportunity to come here, and I'll go everywhere and anywhere. I'm waiting to see the deputy health person in Canberra as well. It's up to you guys to say, here's a list of people who would like to come to your meeting. I can't go to the parliamentary meetings. I've already asked. I ask Rose Jackson every time I meet her, and I always say, I know you can't let me go to that, but I need to go to the next one, because until we push for something, it's not going to happen. And this state is the most fantastic state in the country, on the planet, and it's the fucking worst one to do anything. Every other state has solutions to lots of different problems. Why don't we? We're not that great. Fuck off, Premier. Thank you. That's all I've got to say, and I'll say it again and I'll say it again. And I just want more people. I mean, I've had there's 3 things that I've asked for. Police out of first response, national database, so that the hospitals have them, they don't look at them and they don't share them. Supported accommodation, and I've already gone to the health minister with this, and also to Clover Moore's office. Both of them are working on it, and that is that in each housing commission they should have a group of people who form, there's someone paid a minimal amount, they have a safe room, that they have a health support worker, a police person not in uniform, and it's a community and a society and not isolated, because you've got lots of people, including a lot of elderly people, who never go out, never do anything. It's there, but nobody wants to do anything because they're so busy helping the building industry. Any questions?
I would like to add, I talked about the suicide prevention sector as organisations, governments and things like that. Suicide prevention sector is bigger than that. The first person I reached out to was my mate. We are the suicide prevention sector, but we have to get involved, and that means getting involved politically. That means supporting being. That means asking certain ministers why being is so poorly funded and can barely actually support us. We actually have to get seriously involved, and we have to start asking governments why they're putting money where they put it. Dollars tells us what is valuable. When governments don't put dollars towards solutions, they have said, we do not count and we are not valuable. This means we have to get active. See, as Aussies, we sort of sit back and we don't get involved in political stuff particularly well. And we've done it less and less. We need to get involved. It doesn't matter what your colour of your politics is. We need to get involved with our ministers. We need to start asking questions. We need to make our voices known. Otherwise, nothing will change. It'll remain the same. Thank you.
I also went to I was invited to come to the Men's Health suicide prevention, and it was a really good day. And each of the organisations who were there decided that it would be a great idea to get a bit of unity going and to talk to each other. Statistically, they're all spending the same amount of money and so on. I know that hasn't happened yet. The other thing that was very highly on the list of let's do it is the peer support and lived experience. Where's that? That hasn't happened. And when we had this happen to us, I rang every single agency because our families don't get support and the police families don't get support either. And if my son had grown up to be a policeman and shot someone, I wouldn't be happy either. So why don't all these people pull their fingers out of their own budgets and their fear of being cut funded and actually get together and work together so that we can stop all this and have action? And that's all I'm going to say.
Thank you. Some of the points that have been said is it is about our communities rallying together and advocating and doing that as a collective, knowing that we have differences as well. I think that from all people and parties and groups and organisations, something that we don't talk about is leadership. And it takes hard leadership and big decisions and holding steadfast in those over time. That's what it'll actually take. The investment, the resourcing, having the right skills, changing our approach to risk and how we understand that and promote, and switching to safety promotion rather than risk aversion or mitigation as well. And that takes leadership and holding, and to do that is hard. And so it's how we build the ranks behind us and a whole pipeline of support so that we're successful, because otherwise it will be on the burden and the shoulders of few, and they won't be able to continue in that as well.
While we're talking money and all of that boring stuff, but very essential stuff, so I've accessed safe havens for quite some time, even during COVID. I do appreciate the anonymity that you mentioned, but anonymity doesn't generally generate statistics, which is what gets funding. So I know some places where staff then, they don't budget, but they kind of fill in. So yes surveys, I think they're only New South Wales based. You know, and that's the other thing, when you go there and you might have a level of distress, that's why you're accessing it, you don't really want to fill in a survey, like, come on. They are somewhat anonymous, but, you know, so you don't really have to put your name on there, but there are some demographics as well as other things on there, but you don't really want to do a yes survey, let alone the second survey that's specific to Safe Haven. But that's, you know, that's just stuff you don't really want to do, let alone, and there's another survey that some Safe Havens have that do actually have your name on there. So I've been to a few different Safe Havens, and so just to do any of those surveys is just more than we should have to do. And then for staff to then have to do something, whether you want to call yourself Mickey Mouse or not, doesn't really matter, but just to have that sort of thing. But the statistics need to be there to get funding. So where do we find that common ground to generate the stats for funding? That's, you know, nobody really knows. And that's just something that I think government or whoever the funders are need to just accept, that if we could just have, you know, your dashes of we've had 10 people come, and I don't know if someone, just 10 people. We don't even need to know their age. You know, like, doesn't matter. I mean, I know that it's nice to say that they were cold people or that they were Indigenous people, because suddenly we can get funding from the Indigenous funding lot. I mean, that's great, but I don't know. We need to find an easier way to do that. Yeah. Exactly. But that should be acceptable. You know what I mean? Like, I think the government, New South Wales Health, SA Health, needs to accept that. Sorry. The other thing that I was going to mention, I think Roses in the Ocean is nationwide, but their programs don't pay for their staffing. I'm going to say that loudly. All of their workers at their safe space, not Safe Haven, their safe space people are volunteers. They work bloody hard and they're not paid. They need to be paid. Why are they not paid? I will not go there because, and they've asked me to go there and actually volunteer. And it's like, why would I volunteer there when I've been asked to work at Safe Haven and be paid? What the hell? Like, seriously, guys, if Roses don't have they are funded at some level, so some of their people are funded, but none of the people who function at safe spaces are funded. Yet there is a budget for Safe Haven. So why is there not a budget for safe space? That doesn't, you know. So essentially, what happens at safe space is very similar to Safe Haven. So there should be a budget for safe space. So that it's all dollars. We're talking dollars there. So we want more of the functions there in all states, more hours, all of that. That's what we need. My other question that I had, which is quite simple for you, Ellie, is that your name? Yes, fellow South Australian, country South Australian. I'm in Sydney now because small towns, you can't hide anything. So you just said you were talking about not needing to call police and stuff if someone is talking about suicidality. Is that because all of what you do is all peer-based? You have no clinicians? Okay. Very simple question. Because
Yes.
at Safe Havens, there's usually a clinician, so there's obviously a mandated thing. Is that right?
There are different models.
Okay.
So for for LELAN as an organisation, we're a 100% lived experience-led organisation. Our board, volunteers, students, anyone, you have to have lived experience. And we are a consumer organisation, but we have carers, friends and kin around us because they're important too. But we do preference consumer. So that's why we do that. And we have adopted Alt to Sue as a model and the charter. And so it's enshrined in there that choice and control fully around it, and we don't break that. Before you talked about funding, and because we got the exemption for clinical governance, we also got exemption for taking demographics, because it's against Alt to Sue charter to collect any information. It's anonymous. We do take numbers and number of groups and things like that. It can be done if you're trusted and you fight and you hold out. That's why the advocacy and negotiation was so hard. And whilst we have that, I will say that we are under a new contract now from July this year until June next year, and we've been told to make it self-sustainable and won't have funding from July next year. And we are already funding components ourselves. So our facilitators are technically volunteers, but we reimburse them and pay them for their groups and the time that they do, because they are bringing expertise and skill that should be recognised. And LELAN is self-funding that at the moment because we also had a funding cut. But if there is anyone that wants to talk numbers, it's cheap as an option. We currently have a 0.8 project worker. $110,000 is all it takes to have 10 groups running each week or fortnight in our state, online, in person. It's not ideal because we are self-funding itself, but it's not a lot of money we're talking about for the impact and what you can do. And it has taken leadership, my team's leadership, great relationships with our funders to build trust. When we got a new contract manager partway through, they were a bit astounded that we weren't collecting even data or demographics about different identity groups and that. And they said that will make it a problem for you getting funding in the future, and standing there saying we won't compromise because that will break our charter. And that's because we haven't had peer-led models that have had full fidelity in Australia to show they work. There hasn't built the trust or the relationship or the flow of resources around it. And it was important for LELAN and us to hold so strong about that, to prove that peer-led, community-based can be done. So we've had to be uncompromising. It doesn't mean that's how we need to be in the future. It's just now, whilst we start. And we're a systems advocacy organisation. We are not service providers. We could be seen as entering that terrain, but it has been to have a proof of concept to help our advocacy to change the system in the long term. Because we could have sat around tables for 10 years and said, from our work in 2020, peer-led, community-based, that's what people want. Could have said that for 10 years, we need this, it's what people want. And in 10 years' time, Sweet FA could have been done. We saw an opportunity, built relationships with our funding partners and got it. And there's a lot of work to do and still to be done. And the system and sector have had to really grapple. We've held round tables around duty of care and changing risk relationships because we know that that's the whole part of work that needs to change and be worked on as well. It's not just about bringing a service option. It's a much more holistic change that will take years.
I'm really glad that, Ellie, that you brought up the topic of leadership in relation to funding, because I'll be quite frank here. I think whenever topics of remuneration come up, people are often a little skittish. And I think fundamentally, people's lived experience cannot merely be acknowledged, in my opinion. We need to start remunerating people accordingly. We cannot expect, especially in today's NDIS and mental health reform environment, where the ecosystem is moving at the speed of light, for people to not experience consultation fatigue if you're not going to remunerate them accordingly. What Ellie said about leadership, I think, is really pertinent in my opinion, in that sometimes you have to genuinely hold firm and hold space, because there will be people who will not trust your leadership. There will be people who perhaps do not want that macroscopic level of change, or that once in a generation level of change, where some people would be perfectly contented rearranging the deck chairs on the Titanic rather than actually putting people in the lifeboats. What I would say to that, and this is a bit of a sticky and uncomfortable topic, is we have to be more cognizant of lateral violence within our own spaces, and how sometimes we are often the quickest to self-sabotage or sabotage another peer worker or sabotage another one of our peers, when in reality, I think, as other people here have stated, we are stronger together, and we need to demonstrate solidarity if we want to get the funding goals and the other policy reform goals that we want. What I mean by lateral violence is that, to be quite frank and to speak honestly, I am not a white person. I am an Asian Australian person, and I cannot turn that off. That is not a choice that I have. I am a person of color. I'm a cowled, calm person. I have been in multiple rooms, including in lived experience spaces, suicide prevention spaces, and disability spaces, where I'm often the only person of color in the room. And I've even been in situations, for example, where my own colleagues and co-workers have called me the weakest link, or the chink in the armor, if you will, which is, I'm not going to go into why that idiom is perhaps not the most apropos to use when you're describing a person such as myself. What I found really disheartening was how, when I then attempted to report on my lived experience of racism, that I was not only called that I was exaggerating or being hyperbolic, or that I was somehow not even being true, because the unfortunate reality is that when you call truth to power, including in your own circles, there are going to be people who are going to be uncomfortable with that and will double down and be defensive, rather than listening and actually having an honest conversation of examining their own privileges. So I'm I feel very honored and grateful for this conversation that we're having today that is frank and fearless. And I think in order for us to hold space for that leadership and to effectuate that transformational policy reform, which includes remuneration, we, as a community and as stakeholders and peers, essentially, be conscious of not only how are we being intersectional, but how are we actually uplifting the most marginalized voices without actually, inadvertently or not, perpetuating lateral violence and disenfranchisement that we're purporting to be against. Yep.
Thank you, Andrew. The time's just coming around to 1 o'clock, so I think at this stage, no more guests onto the stage, but I'd like to hear from our last two entrants onto the stage, and then I'll ask Priscilla to come and offer some final words.
Is this on? Okay, awesome. Hi, everyone. I'm Kristen. I think we've identified a lot of issues, and I think it was important that, I'm not sure what your name was, someone said that I think it's important we're also making sure that we're looking at solutions and kind of what we can work towards, because it can be quite easy to get passionate about, kind of what's not being done right and all that. And I think what I'm just hearing throughout, the talks today is that, peer work is such a big part of the solution, but obviously that's an easier said than done sort of thing. I guess I had a few things to touch on there. I think we're at a really interesting kind of point in time with peer work. It feels like we're really kind of emerging into a lot of different spaces where clinical people are kind of just now starting to see the reports and the evidence and all of that. So it feels like a very exciting time in the peer, kind of landscape. And, we're starting to see more and more peer leadership roles, because I think for a while when I started as a peer worker about 7 years ago, it felt like there's a bit of a peer glass ceiling. It was sort of like, you're level 3, either that or you're Faye Jackson. And I'm like, okay, well, what do I do between here and there? I'm just going to share a little bit of a personal experience. I recently got actually made redundant in my role. It was I'd stepped up 2 years ago into a peer leadership position where I was starting to do peer supervision, and I was really excited about, kind of progressing, and then, for nothing having to do with peer work at all, I was overseeing an NDIS space. The role became redundant, so that it's been quite discouraging for me that it's kind of, I don't know, what are the other peer options? We're trying to imagine futures as people working in these roles too. Sorry, bit of dry mouth going on there. I don't know. I don't really know. That's not really a question, but I'm just curious to see kind of what the next steps are for peer leadership and supervision, because I know, was it 2 years ago, the first kind of cohort of peer supervisors went through a training. I'm curious to hear kind of what the next steps are there, and I'm sure there's someone in the crowd that could maybe give me an answer, because I know being has been kind of the leaders in that sense. Yeah.
It's difficult to answer the question as a peer worker, because probably the strongest place for training and everything else is actually in health at the moment. We're getting the most support and growing the most support, and we'll be pushing for more. So that's probably where most of the stuff is actually happening and may come out of. The non-government sector is a bit left behind.
Adding to that, I had the immense privilege of being on New South Wales Health's peer workforce review steering committee. So I'll just repeat here what I said there, which is that people ask me a lot of the times why I'm no longer working as a peer worker in the hospital system. And my number one answer is peer drift. I think a lot of the times when you're a peer worker and you are working under buckling KPIs, and you are often asked to navigate essentially the bridge between multiple different worlds, where you're not only supposed to hold space for people with lived experience, but also supposed to almost act as a translator with and for clinicians. It often does create, I think, an element of compassion fatigue and eventually peer drift. What I would like to see more is more peer workers being embedded outside of the health system to help, I think, ameliorate and allay some of those issues that I think have been well described and well illuminated regarding this particular issue. And I think we need to not only support the peer workers and the lived experience workforce already in our health systems, but also help explore how we can embed that experience in thin markets beyond health, for example, in the care and support sector.
Can I just add one more thing kind of on top of that? I think we all want to make sure that we're recognizing peer work as a profession, but I think it is hard when, I think you said peer drift, but I've heard people say, the clinical creep of, kind of the values of peer work kind of start to slowly filter out because of those, meeting KPIs and working in these really, really complex like spaces where you are a translator and you do need to have a lot of kind of those leadership management skills. It's difficult when, we don't want the professionalism to take over, but we want to be seen as professionals. It's a really, really difficult thing to navigate.
Yeah, look, I'm not going to take up much time. I know it's lunchtime, but I just wanted to highlight something that's really come to light in this last bit of the discussion around peer leadership and supporting peer leaders financially, morally, emotionally, whatever level. I've just got involved in a local event. It's a fundraiser for peer leaders, and it's not just in my area. I think it's something that's going to be done. It's going to widen. I'm hoping it'll widen. It's actually a singing event. The arts and music is something that is very close to my heart. I've been involved in a women's community choir for 6 years. We raise money for vulnerable women and children. And basically, I have a very strong connection and inclination towards furthering the arts in mental health and the importance of that for recovery. But this particular event is focused on raising funds. They want to raise $20,000. This is a grassroots event. And this is where I find I'm having a dilemma. I want to do this. I want to be involved. I want to support it. I want to spread the word. I want to advocate for these types of grassroots events to to help people that are going to help other people. But it then raises that fundamental issue of where is the government, where are the other, agencies and people who could be making a really significant difference. I mean, this is piecemeal, and sure, it may well help in one particular location and one particular group of people, but it's all very well to get involved and do it, and I certainly don't want to be jaded about being involved in things like this, because I think they're really important. They bring people together. It's a community event, and it's doing something really worthwhile. But I just jumped up here because I thought, I've got this, and I can certainly give out these if anyone's interested. It's going to be at Hornsby RSL in December, and it's a case of you sign up to be a singer, or you can sponsor a singer, and that money will go directly into peer leaders, supporting peer leaders. So I just wanted to highlight that and just bring that issue up and how important it is.
Thank you so much. Let's leave it there and continue the conversation over lunch, which, as I said, is just in here. Please join us. Thanks for participating today and sharing your views. And thanks also for listening to what other people had to say. And I look forward to seeing you at the next Being event.